There it is. Okay. All right. So my name is Dr. Kristoffersen. I'm a postdoc here at the center. I'm heading the Neurorehabilitation team, and my talk is about stroke rehabilitation using myoelectric pattern recognition. So myoelectric pattern recognition, as Max talked about, is this technique where you measure some EMG signals, you apply a machine learning algorithm, and from that you can get the motor volition or motor intent of the person. And what we've done traditionally is that we use this for prosthetic control, but we recently did a trial where we tried this technique on people with upper limb impairments following stroke. And what we found is that it's possible to use this technique to decode the motor volition of people with upper limb impairments. After me, Maria will talk about the clinical results of this trial, but what I will talk about is some of the barriers we experienced during this trial. So stroke rehab requires a lot of training. It's thousands and thousands of repetitions to regain control again, or motor control. And for that to happen, we need to have this treatment in the clinic, and especially later on also in the home, to ensure that there's enough training going on. And we found three things we're focusing on at the moment. We want to focus on usability, the signal acquisition, and also the physical support. So in terms of usability, so far we've been using Patrick, which is our open source platform designed by engineers for engineers. So it's not really user-friendly for a clinical audience or for the patients themselves. So we are currently developing a new platform called Myocognition, in which you can do the same things that's in Biopatrick, but doing just a few clicks. And this platform will also contain games and activities that will promote motor execution for these stroke participants. Furthermore, we're also looking into the signal acquisition, so the skin electrode interface. And we are collaborating with the University of Bordeaux on a textile electrode band. And the idea of this band is that you can stretch this around the limb you're interested in measuring, and then you do not need to worry about the targeted electrode positioning, which will make the treatment easier and also cheaper because this electrode band is reusable. Furthermore, we are also involved in the graphene project, where one of the partners, ICN2, has developed the Ignite electrodes. These electrodes, they have the potential to be cheaper than the conventional silver chloride because they do not contain any precious materials. But furthermore, these electrodes are very thin, so they conform very well to the skin. And we have done testing of these electrodes in humans, but we also done it in an electrode test rig using agar molds to characterize the characteristics of these electrodes. Lastly, we are also working together with Professor Asplund on the laser-induced graphene electrodes, which I'm sure she will talk more about later today. Finally, we're also looking at the physical support, where we had student Mark Grunwert develop a first orthosis to help give physical support to these stroke participants. And physical support is needed because a lot of people with stroke, they tend to have spastic contractions, which we want to reduce, but also because we want to have the ability to lock individual joints. So for example, we want to focus on the wrist joint, then we can lock the elbow joint so they can focus on the wrist joint only, and vice versa. One requirement for this orthosis is, of course, it does not cover the electrode side, so that's why we had to develop our own solution instead of using off-the-shelf solutions. So these are the three barriers we're working on at the moment for MPR for stroke. If you have any questions, please let me know. Thank you.
Hi everyone, my name is Maria Munoz. I'm a physiotherapist, and now I will start next month my PhD with Gothenburg University, and I have been already 3 years collaborating here with the lab. So my job is mainly in the rehab part of the story. So as Max said in the beginning, we have this multidisciplinary team, and I have been working mainly with the rehab. So today I will talk to you a little bit about upper limb training that we are doing with artificial intelligence, virtual reality, and serious gaming. So as you must know, our work these years have been mainly before with prosthesis, then phantom limb pain, and now lately we incorporate stroke, and we start with upper limb function in stroke. So we know that 15 million people around the world per year have a stroke, and around 50 to 70% of these people present upper limb impairment in the acute phase. But then also after the 6 months of the onset of the stroke, they still regain this upper limb disability. So what we know and what we have seen in the evidence is that in the beginning we have a spontaneous recovery of upper function, but then normally at the 6 months after stroke we reach a plateau. Evidence has seen that we can still have a little space to increase or decrease upper limb function. So, but we are trying to increase the upper limb function, so we decide to use this gap with chronic patients and to do our first single group clinical trial. So we choose 6 chronic stroke patients with low function in the upper limb, according to the Fulgo-Meyer scale. And we did a protocol of 18 sessions. First, a period of assessment. We use Fulgo-Meyer and ADAT, and then we use 18 sessions where we use our open source treatment that Morton indicated before, that I will detail later on. And then a period again to analyze and see how this upper function have changed after our treatment. The protocol is 18 sessions, 3 times per week, 2 hours. And in parallel with this study that is in collaboration with Gothenburg University with Professor Margit Armorfer, we are doing a qualitative study to see also how is the response of the patient in front of this treatment. So how is worked the training session? So of course it's completely different with amputees. Now we have the limb. So we use this affected size of the stroke patient and we use the surface electrodes to gain and get the muscle activity, and we use that with virtual reality and serious gaming to train the upper limb function to relearn these movements that were affected after the stroke. As Morton was saying, we have a lot of spasticity and mobility impairments with stroke. So we are trying to re-engage with the patient mindfully training and learning with this real-time feedback with our open source training system. So what have been our results? For example, here we have a participant that in the beginning he was not able to actually open and close the hand in a coordinated way, a lot of spasticity and a lot of concentration to actually be able to perform the task. So you can see here the therapist is trying to actually help and open the hand. But after our treatment, what we've seen is that the participant was actually able to grab the ball, and not only grab it, also release the ball, which is quite a big improvement. So as you see, the therapist and the patient are both quite happy and surprised, like, oh my God, this worked. And it was incredible to see that result. We have another participant with a little bit better upper limb function that, as you will see in the first video, she's really trying to do a thumb extension, and she is really trying to focus in that movement, but she's not able, so actually she's helping with her other hand. And you must see it's not much happening, but after our sessions we see that we teach the participant to actually control the muscles in a mindful way, and now she's able to flex, extend the thumb, which is a very important function to grip and to do daily life activities. So this is mainly our stroke trial. We had been a little bit delayed because of COVID, but of course we plan to finish at the end of this year, hopefully. And as Morton was saying, as also the team, this is our first stage with this technology, and our future aim is hopefully to someday go to home use and then do rehab in that stage, but we're in the baby steps now. Another interesting project that I have been working during this late time, it had been with a hand transplant patient. So Dr. Paolo Sasu has been directing this project. Some of you know, but at the end of last year, there was the first hand transplant patient performed in Sweden, a bilateral transradial patient. And in collaboration with Dr. Paolo Sasu, we have been helping during this process. So with also the OT of the team, so Annika and Maria, we had been doing different protocols to help the patient, and we have been using also this augmented reality training to prepare the participant. So we start using it before the surgery, so we actually train around 2 years with our virtual reality training to prepare the muscles for the patient, so for the time when she will have the actual hand, and to start learning the different like finger movements, and also help to decrease the phantom limb pain that she was suffering. Now I can show you some videos after the training. Now with the hand, we are still training with the same technology, but of course focusing more in dexterity and trying to promote the individual finger movements. And I want to finish showing you this cool video. I hope we can show it. This was a couple of weeks ago. The patient sent me this video. I think it's amazing. She said, like, now I can play the piano, so to say. We are just in the initial stages, for sure. But as you see, she have also independent control of the fingers. Dr. Paulo Sasu will detail you more later on, but this is our initial stage, and very excited about it. So if you have questions, please. Thank you very much.
We have a question from Slido, and the question is, do you think you are overcoming post-stroke spasticity with this methodology, or do you have a combination therapy with botulinum toxin?
So, some of our patients have botulinum toxin, the injection of Botox to decrease spasticity. So we try to, our patients that we recruit are after at least 6 months after Botox. So we are not considering that. And of course, we believe that we have help with the spasticity. We do the Ashworth test to also to see if we have any difference. But for now, we cannot ensure that that's the reason, but yeah, we have seen that spasticity decrease with these patients, and the motor control and the upper limb function coordination as well. Thank you very much.